I think that's a big misconception is it's RSI, rapid sequence intubation, right? So I think a lot of people hear the word rapid and they're like, oh, it's a quick procedure.
Right.
It's not. The rapid is the drug induction. It's not a procedure you want to rush through if you don't have to. It's a dangerous thing to do. You're taking someone's ability to breathe away from them, essentially.
Sounds right.
Welcome to In Service, the EMS Podcast, where frontline experience meets leadership insight. Hosted by Jason Falvey, a seasoned paramedic and EMS leader with over 30 years in the field. This show brings you conversations with people shaping emergency medical services today. From street-level medics to innovators on the bleeding edge of EMS, we dive into real stories, leadership strategies, and what it takes to build high-performing teams in high-stakes environments. Let's get in service.
We copy you down, Eagle.
Today's guest is Ricky Bias, an experienced paramedic whose career has taken him through nearly every side of EMS. From rural 911 in fire-based operations to critical care transport, flight medicine, and leadership. Ricky began his career working in rural EMS, where long transport times and limited resources helped shape his approach to patient assessment and clinical decision-making. He later transitioned into flight medicine, serving as a flight paramedic before moving into leadership as an airbase manager. That combination of ground EMS, critical care, aviation, and operational leadership gives Ricky a unique perspective on what happens when we call for a helicopter and what ground providers can learn from the culture, safety practices, and clinical expectations of flight medicine. Let's get into it.
I remember I was just for a buddy of mine that I used to work with years ago. We were cracking up over the first baby we delivered, or the first one I had delivered. And I've done several since then. I was on the ground at that point, but the scene was so chaotic and funny. It was funny to think back on. That's a memorable one. I've had another one that pops up, had a transformer blow directly above us on a wreck one time, dropped the power line across the car, things like that.
I've been doing this a long time.
Yeah.
Never delivered a baby in the field.
Really?
Came close one time in the 90s.
Really?
Show up at the house, Gravita 5, Para, whatever,
Oh, yeah.
and contractions under a minute.
Yeah.
And they're shoving her out the door. Okay. I have my OB kit. I'm going to set up. Let's deliver right here. I'm super excited. This is it, right?
Yeah.
Man. They get her on the stretcher. They load it in the truck. And I'm standing there with the bag open thinking, what are you guys doing? She's under a minute. We got to get her pants on, right? They load it in the truck. I hop in the back. And I'm like, no problem. We'll deliver right here in the back of the truck, right? Boom. I start getting her ready. Back door's closed. Bang, bang. I'm looking around for my partner. He's in the front seat. Don't worry, I'll get you there. And he hammers it. Like 100 miles an hour. Stuff's flying out of cabinets. I'm all over the place in the back. I'm trying to get her pants off. Yeah, it was a disaster. And at some point, you look out the side window and you're like, we're literally a block from the house at this point. So I pick up the radio. I call in.
Yeah.
We back in. He opens the doors. We made it. There's stuff everywhere. Everything came out of the cabinets. And two-man stretcher. So now I have to hop out, pull the stretcher out, drop the wheels. I'm just in shock from the ride, from the moment stolen from me.
Yeah.
We go through the ER, we get in the elevator, up to the second floor, right into labor and delivery. As we're moving her over,
She delivers.
baby comes right out on the sheet.
It's crazy.
Yeah.
It's crazy.
Stolen from me.
And I always think that's so interesting, man, is you can do this. You've been doing this for over 30 years. I've been doing this for over 15 years, so half the time. So it's crazy the experiences that each individual provider has and how much they can vary from person to person, and it doesn't really matter the time frame. I don't know why that is. I don't know if it was the area that I was in that we just happened to, we delivered a ton of kids. I think I did. In the 5 years I was down there, I probably cut like 7 or 8 cords, probably caught a handful of those, or somebody else just.
Right.
It's interesting the way it falls. And then you have somebody else who's been doing this for 30, 40 years, and they've had it once or twice. It's interesting how our experiences vary. And then there's things you've probably done a million times that I've maybe done once.
I've done more shootings and stabbings.
Yeah.
I was in a city with a very prevalent knife and gun club. We did them all the time.
Yeah.
For me, you do so many of them, I think it just runs pretty smooth.
They almost become routine.
Yeah.
They almost get, everyone loves going to the good traumas. Everyone loves the shootings and things. But when you've done them so many times, like if you're in an area where crime is prevalent, they just become so routine. They almost become mundane. Unless the patient is truly like sick and you're having to work your butt off back there, they're almost just all the same.
Yeah.
You patch them up a little bit, you take them to the hospital, start your IV and all, you do it over and over. You get into a routine with it.
Yeah. Hey, thank you for coming in this morning.
Of course.
Appreciate you doing this and taking your time out. We talked about doing this several weeks back. We went to a training program together, which I actually found really good.
Yeah, I've been meaning to follow up with you on that to see how some of that went. We'll side.
But where'd you grow up? Where are you from?
Yeah, so originally I'm from Georgia. I'm from Columbus, Georgia. It's maybe hour 45, 2 hours south of here. I born and raised there. Ended up went to a little college down there for a little while before I decided I wanted to go to EMT and paramedic school. I ended up getting into EMS in a very rural area of Alabama, Macon County, Tuskegee, very, very rural. And we ran, depending on the shift, 1 to 2 trucks, depending on how much staff we had at the time.
Second truck sleep all the time.
We used to rotate the calls. We were running the same building. We would rotate calls. If they had the staff to staff it that day, we would rotate calls. And then they moved that truck out to a different station in the county, and it did nothing. They had a contract with the VA, so we stayed busy with those. When you weren't doing those, you were doing the county 911s. And so for a rural service, between the IFT and the 911s, it was, you were getting beat down pretty hard. And you had long transports, 45 minutes, an hour, depending on where you're coming from. Great place to come up in EMS because you really honed in your assessment and you're hands-on with the patient. You know, like, it was great. Don't regret any of that. Made me a very confident provider. But yeah, did that for a couple of years.
Did you spend more time on scene, or did you just load them and go because you knew you had a long ride?
A lot of load and go because we had a long ride, no matter how sick they were. And, you know, this was 2010. So to you, you're well into your career at 2010, right? But so that doesn't seem like it was probably that long ago because it doesn't to me. But the times have changed a lot since then. I was with, my partner had been in EMS for 20 years at that point. So she was very old school. It was very much, we're going to throw them in the truck and you better be able to do everything in the back by yourself or you're worthless. You know what I mean? So it was a lot of just loading them up and heading to the hospital because you had 45 minutes, you know? So if you do everything on scene, you're just going to be staring at each other on the way to the hospital.
I spent a lot of my career in an inner city up in Massachusetts. We did a lot of work on scene because the transport times were 7 minutes, 6 minutes. There were multiple hospitals in that city. So you did a lot on scene. If you loaded them in the truck, you were going to do nothing for that patient. So, but what drew you into EMS in the first place?
When I was in high school, I wanted to be a firefighter. I went through the whole thing of I wanted to be a teacher, or I wanted to be a doctor, I wanted to be an architect at one point. And then for some reason, I locked on to I wanted to be on the fire department and I wanted to be a firefighter. At the time, to get into fire and even EMS, it was very competitive. And so I was pretty much told to get a leg up, I needed to go to EMT school. Go on and have that done, at least your EMT basic, because at the time in Georgia we had EMT basic, you had EMT intermediate, and then you had paramedic. Intermediate ended up changing to advanced to use in Georgia now. Well, whoever's using National Registry, but in Georgia we had the advanced EMT. So I went to EMT basic school. I tried to get on at my local fire department. At the time, first time I tried, didn't get on. And I said, well, I'm going to go work as an EMT for a little while and go on to paramedic school, make myself a little more valuable, right? So started doing that, started paramedic school. That put me about 2 years into that plan.
Right.
And that's when I applied again with that fire department after paramedic school. But the whole reason I got into EMS was because I wanted to be a firefighter. Had no idea I would fall in love with EMS. Had no idea I would end up spending my entire career more in EMS than in fire.
Yeah.
Sorry. It kind of unintentionally, I guess you could say.
Yeah.
But yeah.
I think people that get into public safety, police, fire, EMS, they just want to be involved, right? You want to be a part of whatever's happening. and be there at that worst moment, right? That critical moment, and bring your knowledge, skills, and abilities to bear on the problem.
Yeah.
Teamwork too, right? You're part of a unique group of people.
Right. And that probably drew me in as well because you get that whole teamwork aspect, right? I grew up playing sports and things like that, so it gave me some fulfillment. And you're right. Like, I absolutely hate that people need us when they do, because it's some of the worst times in someone's life, right?
Right.
I hate that someone has to be there to do that, but I want it to be me, right? That's what I wanted. I wanted to be the person that was there helping them. I think that's something, like you just said, it kind of draws us into it, right? We want to be that person present. We want to be there helping.
Yeah, because, there's a bad car accident, right? Either you want to get as far away from that as possible, or you're paralyzed looking at it. And today, now somebody's filming it, right? Or you want to get involved, try and get the person out of the car or whatever it is. Mm-hmm. And I think for us, we definitely want to be involved, which I think makes us a really unique group of people.
Yeah, I agree.
Do you have any calls over your career? I know we started to touch on this earlier, but that just stand out to you? I know you got thousands, right? And how do you choose? Right?
You have all the little flashbacks that start popping up, right? And of course, you have the ones that are bad, that people love to hear about the bad stuff, right? That's really what they're asking a lot of times when you're out in public. They're like, what's the worst thing? Sorry.
You're good. For me, I don't mind talking about that stuff. I think it draws some of the bad energy out of it for me, and I don't have a problem talking through it. But I totally understand people not wanting to relive a call that has affected their life, affected their quality of sleep in what they do. So I totally respect all that.
Yeah, and I think it's a really good point, because it doesn't bother me either to bring that stuff up, because I don't blame them. That it's honestly what we just got done talking about. That's what we were drawn to EMS, because we were interested in all that stuff. So I can't blame someone for being curious and want to hear about it. So I could go down a list of the cool, gory stuff we've seen. But the stuff that really stands out to me, like I was telling you earlier, is probably a lot of the first time I mentioned to you, the first time I delivered a baby, and just how cool that is to say you did and you were part of that, especially if it was a healthy birth. And fortunately for me, the first one I did was a super easy, healthy kid. I'm a new paramedic, so I'm probably super nervous. This lady's not even all the way on the stretcher. The baby's shooting out. I got an EMT. I'm asking him to get the OP kit. He's opening the OP kit, and he can't get it open. It finally just explodes. Stuff goes everywhere. He can't find the scalpel.
The bags aren't easy to open.
They're not easy to open. So stuff like that stands out to me. The funny stories, that stands out. I mentioned to you the transformer. Had a transformer blow over us at a wreck one time where we were trying to get a guy out of the vehicle. The transformer blew. It dropped the line across the vehicle we were at. Everyone scattered. We all ran back to try to get this guy away from those hot lines. And I don't know if it was a transformer or the line or what, but there was another big explosion of electricity. That one stands out. And then we've got some like big burns and things like that. Probably the first time I RSI'd someone, the first time I needle decompressed someone. I remember all those things vividly. Those are what stand out to me. My first experience of something, right?
Yeah. And, needle decompression, that typically for most paramedics is pretty much a low frequency.
It is.
Yeah.
It's a low frequency, high acuity thing. Mm-hmm. I did it once on the ground, and I've done it flying, but numerous, right? And I'm not saying that to be like, oh, I've done this, but it's just because your definition of acuity, of high acuity, changes. The patient that I might see once a month or once every few months when I was on the ground, at least in my experience, I was doing that maybe a couple times a week, right? Wow. A couple times a shift even when we were flying, just depending on what was going on. So, like I said, your definition of acuity would change, because this patient that I would consider really sick on the ground,
it's routine.
That became a routine one in the air, right?
Yeah.
And we still fly low acuity stuff too. So I'm not saying all I do or all I did was high acuity things, but it was just the frequency of higher acuity patients you were seeing more frequently, right? So, yeah.
So you're a flight medic and you're an airbase manager. Mm-hmm. And what got you into flying other than the jumpsuit?
Yeah, I mean, it's a
cool
super,
helicopter.
It's like wearing pajamas to work, I know the jumpsuits are terrible. They're hot in the summer, they're cold in the winter, so any draw to those, you get over that really quick. Yeah, that's, I was always interested And just because, working in a rural setting, we flew some patients every now and then. I was like, oh, that'd be really cool to come do that,
I think every medic really, if they're worth their salt, right?
Yeah.
They want to get better. They want to be right up to the edge of excellence.
Right.
You're naturally going to be drawn towards that route.
Yeah, there's more training, more credentialing. I'm growing myself trying to get there, right? But I had no intentions to go do that for a living. I was happy where I was at with the fire department at the time, loved doing what I was doing until I didn't. And that was because we started getting into a paramedic shortage. I was spending more and more time on the ambulance because we did a hybrid type thing where we split between our trucks, our engines, and our ambulances.
Right.
You would get beat down pretty hard on an ambulance. And I'll be honest, I got a little burned out from that. I just said, I got to find something else to do. They had an opening at one of the air bases near my house, about an hour away. I applied there, ended up getting a job offer, and got into it. I just kind of went full tilt into that, went the other direction. Didn't think I'd ever leave the fire department. Ended up going over to the HIMSS company that I went to over there.
I want to ask you about your first day, right?
Yeah.
But you don't really need to be flight certified, right, to get hired in. You need to achieve that credential at some point.
Well, yes and no. At the time, correct. You typically get, most companies are going to give you a 2-year grace period. The only thing that can change that is state licensure. Some states may require you to be able to perform to that scope.
I can't imagine you getting into that role and not having that credential. I think that would create such anxiety.
So, like with Alabama, you have to have it beforehand because you have to get your critical care endorsement on your license, and that's one of the requirements, is to have that beforehand. In Georgia, you can do your 2-year grace period. That may have changed a hair because they're doing this. I used to get the grace period, but Georgia's now moved to this CCP license that they have as well. But yeah, it's a lot of on-the-job training, but it is a little intimidating if you didn't have that license or that certificate beforehand, that FPC or CCP or whatever certificate beforehand. It's intimidating because you're seeing some things, especially if you spent the majority of your career as a street paramedic running 911 calls.
Right.
And now you're stepping into an ICU and a patient's on a balloon pump and 9 drips and multiple pressors. And
what's this button for?
yeah, what are all these alarms going off? You're looking at your nurse crazy, or even just as a 911 medic, you're seeing it more frequently now, but even just ventilators. You didn't typically fool with ventilators much.
Yeah.
You are starting to see that now, right? But at the time, we didn't carry vents on our 911 units. Mm-hmm. So it was a big learning curve. And of course, you're immediately kind of getting into studying for that certification because those 2 years go by quick.
I bet.
Trying to get that cert.
So what was the biggest surprise for you day one? What stood out to you? You show up.
Oh, the downtime.
Yeah.
You walk in, you're coming in as the new guy, and you have this expectation of all these people who've been here for years, high-level providers, a lot of type A personalities. But there was a lot of downtime. During the downtime, we're expected to train and study, but there was just a lot of time to rest and do whatever, especially when I came in. It felt like we had bad weather for 3 weeks. I don't think I had my first flight for 3 weeks. And you're itching to do it, right?
It's got to be maddening. Yeah.
I went from running 17, 18 calls a shift at a fire station, and then I come in here and I don't do a flight for 3 weeks. So just the downtime and just finding things to do, productive things to do in that downtime.
Yeah. Gosh. Wow. So would you have any advice for somebody who's thinking about getting into flight?
Yeah.
Do you think that a person should wait and accumulate 5-10 years of experience, or somebody who's maybe 2-3 years out would be a good candidate?
I don't think there's it's never too early to start your studying and knowledge growth. It's never too early, but I would make sure you have a really good foundation as a paramedic first. You really need to know your job. You really need to hone your basic skill set and have confidence in yourself, have confidence in your patient assessment, because you're going to have to be able to do a really good patient assessment. Just anything hands-on with a patient, just be confident in that. In your decision-making, you're going to be making a lot of timely decisions. Stuff like that you need to really hone in on. Then you can start moving into getting more into the weeds of the education, right? Just any of the stuff you're going to be studying for your FPC, your hemodynamics, and,
Right.
and your ventilator settings. Just get good at the basic stuff first. Don't get too far ahead of yourself.
Right.
Because you're going to get in over your head really quick. Regardless, even once you're ready, you're going to get over your head. Just get really good at the basic stuff first to become the best person you can be at your job, and then start moving in that direction.
And depending on the system you're in, the system we're in here is usually about 1.5 to 2 years for a new medic here. What I'm finding, what I see is they've pretty much got a good cross-sample of patients, of different kinds of patients, where they're really hitting that mark where you can pretty much give them anything and they're going to handle it.
Yeah, we typically require 3 years minimum as a paramedic, right? And it says in a busy system. So 3 years in Metro Atlanta versus 3 years in rural Alabama, you're going to see very different things. You're going to have a lot more outpatient side time on those rural transfers, but you're going to have a lot larger pool of patients in a metro area, right, in a Metro Atlanta area. So those experiences can vary drastically. You're going to be very good at very different things. So I would also push somebody to experience different EMS. If you've worked nothing but Metro Atlanta, you've got 10-minute transports or something.
Right.
You got all the hands you need on scene. You got plenty of people helping. I would encourage you to maybe do part-time somewhere in a rural area, in an area you're going to have longer transport times. You're going to have longer outpatient side times. You're not going to have the help you're used to having. And just experience that patient population, right?
Right.
And vice versa. I'm a paramedic that works out in the middle of nowhere. Maybe I pick up part-time a metro area, right, an urban area, because it's a totally different experience.
Yeah.
I think you should be able to lean on both of those experiences.
And you managed actually an office in a pretty rural area.
For ground?
Yeah.
Yeah, I did for about 1.5 2 years.
But you come from that realm. What is that like? Your experience level crosses so many different areas, right? What are the challenges in rural? I know you said you probably won't have the personnel with you on scene that you have in a metropolitan area, but what are some of the other challenges in a very rural area? Because rural for me, well, down here, I live pretty rural. My experience as a paramedic, rural was, okay, now we're going to have maybe a 25-minute transport time. You're looking at much longer.
Yeah, so in the area that I was managing in, they've got a local facility there that's, they can be there probably the farthest point they can be there in 25 minutes to that hospital. But it's more of a low acuity hospital.
Community.
So their next closest trauma center is 45 minutes. Their next closest level 1 trauma center's a little over an hour. It's interesting. So it's staffing in a rural area is interesting, right? Because you don't have a large pool of candidates to choose from. You got to deal with paramedics and EMTs that are able to make decisions without a lot of help and help develop some of that confidence in them if they don't have it. And one of the biggest challenges was probably when it would get a little busy and you got calls holding and deciding which calls they need to be going on, triaging calls pretty much as they came in, because I might have 3 trucks running at night. Well, I just had 5 calls drop.
Yeah.
Do
you think it's easier to go from a busy metropolitan area and work in a rural EMS setting, or go from a rural EMS setting into a busy metro area?
To me, it's easier to go rural to urban, because if I went rural to urban, I should have my confidence and my skill set built up enough to where I'm confident in my decision making, that when I come into this urban environment, my biggest trouble is going to be, wow, I've got more help than I'm used to. So how am I going to delegate these tasks? But it's a challenge then too, because sometimes you're used to throwing somebody in a truck and then you're at the hospital in 5 minutes and you don't have more time to do interventions or whatever. So that's a change. And when you go from urban to rural, it's you're the provider there. You don't have much help. So in my opinion, it's easier to go from rural to urban. That might vary. That might be different, somebody else's opinion.
My opinion,
Yeah.
I would think it would be, just from an experience standpoint, to go from the metro area into a rural area, only because at that point you have the you've seen a good cross-section of patients, right?
Absolutely.
You're not going to get caught with this, and we talked about CHF patients the other day. You've probably seen 100 of those. And all the varying levels of severity. And I think being armed with that experience would make being able to deal with less hands and a longer transport time easier. That's just how my mind worked through.
That's a good point.
Yeah.
I don't know. That's a loaded question, kind of.
I know, right? I don't know. That's kind of how I look at it. And but I agree with you. I think that if you've been a paramedic for a while, it's good to experience different systems and how they operate. Even for me, right, transitioning down here to the South, EMS is run differently. Patients, right? We're still seeing some of the same things. The way it functions, the way the different agencies work together, completely different.
Really?
Yeah. So is a helicopter just a faster ambulance? Or, right, the decision to fly somebody, it's got to be more complex than that.
Not always. Sometimes it truly is just about the speed of transport. And a lot of my medics or nurses, they might slap me for saying that because they want you to think that they're doing these crazy interventions and things like that all the time. And they are. When they need to, it's a great thing, right? But a lot of times it really is just about getting from point A to point B, getting this patient to definitive care as quickly as possible. I feel like that's becoming more common. We're seeing a lot of progressive fire departments and progressive EMS departments who are starting to do a lot of the interventions that you used to only see the HIMSS crews doing, the critical care crews doing. You're seeing everyone's moving into blood products now, which is amazing. It's incredible. It's saving people's lives. That was a tool that we used to bring to the table, and we still do bring to the table.
Right.
You're starting to see a lot of departments do that now. A lot of services move to that now. Even in the metro area, you're seeing it with wonderful results. You're seeing departments and services move to RSIing patients. Some of these tools that we used to offer that kind of made us different, you're seeing more frequently on the ground. So when these people are calling us, it's literally, hey, we need to get this patient moved. We don't need to throw them in an ambulance for 45 minutes or an hour. Let's get them from point A to point B as quickly as we can.
Blood, RSI, right? There's a lot of talk about ultrasound out there. You're bringing a much higher knowledge level and skill level to the patient. I think that's a huge advantage.
Yeah, I do agree. I mean, because everyone's coming in with fairly vast experience already. I've got nurses who have been on the job for years, paramedics who have been on the job for years, and then have been trained to our standard as well, educated to our standard. So they are bringing a lot to the table. But when it's needed, they're absolutely the person that you want there for that. But it seems to be so much more common for us to be used for a mode of transport, essentially. I saw a really big difference during COVID. EMS as a whole has changed a lot since COVID, since 2020.
That was a wild time.
It was a wild time, but services are not staffed as well as they were pre-2020, especially in these outlying communities, these hospitals that need transfers done. They're having extreme difficulty finding services to transport out of their county. A lot of times we're getting calls to transport a patient that would normally just go in an ambulance on a cardiac monitor. We're getting calls because they have no other transportation available. That's one of our reasons for transport is no ground transport available. But with that being said, of course, they still do bring vast knowledge, vast skill set to those patients that do need it. But
I did an episode out in Middle Tennessee, and that organization flies trauma, stroke, and STEMI. Just because the community hospital they have there doesn't have those capabilities.
yeah, they probably got a long transfer to the next facility.
Yeah.
And then you say, let's say I've got...
They're looking at an hour ride into Nashville.
Yeah. We go to communities that have one ambulance, right? You got one ambulance, and this patient needs to go to a trauma center. Let's say we're picking up just over the border in a small county in Alabama, and their closest trauma center is Birmingham. That's almost 2-hour drive for them. So one ambulance, 2 hours to Birmingham, they have no coverage in that county, right? Or that hospital that's in that county, it's just a critical access hospital. They've got a stable patient that's really just kind of chilling. They don't need anything special. And they call that EMS agency and ask if they can transport them. They're going to be gone. That's a 4-hour round trip. That county is going to be completely uncovered. And so they'll call for air, right? So, yeah, we're seeing a lot of that.
We were talking to Derek earlier. He's from Wyoming, and he said it's not uncommon out there to have a 5-hour transport time.
Yeah, I can't even fathom that. That's insane.
And they shut the highways down during the wintertime because of a storm might come through the pass or over the mountain. It's crazy.
That is crazy.
What are some of the clinical indications that makes a patient worthy to fly?
Anyone that needs to get to higher definitive care. Let's say you've got a stroke patient and you're concerned they need to get to a comprehensive stroke center. They need to get to a stroke center, maybe whatever scale it is that your service is using for large vessel occlusions. Maybe they're showing a high chance of a large vessel occlusion and they could get to a thrombectomy capable facility. Right. So trying to get them to a higher level of care. Trauma patient who needs to get to a level 2, level 1 trauma center. Burns. Most places have very few hospitals that treat burns, and they're usually very far away from wherever you are. Pediatrics, whether there's severe medical issues, traumatic issues, is that kind of what you're asking?
Yeah. What are some of the biggest misconceptions about that ground providers have with helicopters and flight crews?
So one of the things we probably hear the most is you'll hear people make the comment, oh, if there's a cloud in the sky, you don't fly or something. Or if sometimes they'll call and we decline something for weather, and you look up and you're like, man, there's not even a cloud in the sky. It's blue sky. A lot of times they don't think, not only are we looking at the weather where we are currently at, like where we're based out of or we're leaving from, we have to look at the weather where you are, where we're picking up from, the weather that's in between the two,
right,
and then the weather from where we're picking up to where we're going, the weather all in between that. We might be going 2 hours north of where you are right now, and the weather could be drastically different there.
Right.
And also the forecasted weather. It looks good now, but is it forecasted in 45 minutes? Or are there thunderstorms moving in? We'll have ground EMS agencies that get frustrated because they're thinking, well, the weather looks great. Why aren't you flying?
Right.
When it's weather they can't see, or they don't see yet, at least.
Yeah. And the weather here in Georgia changes so quickly.
Especially in the summertime and the spring.
Yeah.
Fog loves to set in the spring and summer. Mm-hmm. The early morning hours get a lot of fog.
So on a scene flight, you land, you head into the ambulance or to the crew or to the patient. What makes a good handoff? What are you looking for in your mind, right? I'm sure you've had some terrible ones.
Oh, yeah. I've done some terrible ones. Given some terrible ones.
What makes a really good handoff from a ground crew?
If I'm coming in to fly your patient, the earlier I can make contact with you, the better. Sometimes that's when I'm 10 minutes out. Sometimes that's when I'm climbing to the back of the truck. The first thing we're going to want to know is how much does the patient weigh? That's important for multiple reasons. We got to be conscious how much the patient weighs because we got to know what do we look like with how much fuel we have right now, how much can we lift. Different airframes have different capabilities, so we might have to burn some fuel off if the patient's really heavy, or we might be fine. And then the other side of that is almost all of our medication dosages are weight-based, right? A lot of our stuff's weight-based for our peds, but almost all of ours, adult or peds, is going to be weight-based. So we'll go on and jot that down. Go on and start getting some of our common drugs calculated and writing that down on a piece of paper or a piece of tape or something that's on our leg. An airway status. You can tell me that stuff right off the bat before I even lay eyes on the patient. That'll tell me a lot. I can start getting ready. If I know I'm going to take this patient's airway, or I think I might have to take this patient's airway, I can go on and start getting prepared for that. I've got the weight, so now I can start writing down my RSI dosages. I'll have all that on hand. We don't have to calculate it once we're in the back of the truck, 'cause it's already going to be chaotic enough. Once we land, we can get the rest. I'll hop back there. Tell me what the problem is. Tell me what you think's going on. Just like you would give your handoff at the hospital.
Right.
Yeah. Tell me what you've done already. And a lot of times, these crews are great. A lot of times, they've done everything. You've got a packaged up patient ready to go. We'll still do our assessment, but
I can remember back in the early 90s, we got sent out to this crash in the highway. Rural for the standards of the time, of the area. Pretty rural area, and we got sent out because we were ALS to intercept this BLS unit that had a patient that was ejected. And so as we're getting on the highway, we're maybe a mile from the scene. They cancel us off. They got a helicopter coming in. I said to my partner, I can see the wreck. Let's just go down there and give him a hand. So we roll up to the scene, and there's a 17, 18-year-old girl laying in the median, and there's an anesthesiologist there. And he says to my partner, hey, do you guys have a tube kit? I'm going to tube this patient. So my partner is like, okay. He grabs the tube kit, gives it to this doctor. He starts trying to intubate this patient, laying in the dirt in this rainwater runoff.
Yeah.
Right? There's dirt in the mouth, broken teeth, God knows what. And he's like sweeping it out with his finger, and he's trying to tube this patient. And I remember seeing the helicopter goes over our head. The state police shut the highway down. And I go back to the airway. So I'm trying to suction the airway out so he could drop the tube. And he can't get the tube in. So he pulls it out and he bends a hook in it. It's covered in sand. It goes back in the airway. And I'm looking at this at the time, and I'm like, this doesn't seem right to me. This is not. But just at that moment, this flight medic taps me on the shoulder and says, what do you got? I'm like, well, I don't know really anything about the patient.
I walked up.
Yeah, I just came in to give him I'm like, that's a 17-year-old girl. She was ejected. I said, this is an anesthesiologist. He's going to put the tube in. He's like, we'll get it in the air. And they grab this patient and go.
Yeah.
That was my first experience.
Wow.
Yeah. Pretty unique.
Pretty sick patient, too. That's crazy, man. Kind of makes you cringe
Completely
thinking about
unresponsive.
that, too. Yeah. Oh.
I'm like, God.
But lesson learned there, you know, man.
And my partner at the time was like, I saw him do hundreds of intubations, never missed a tube. And he's handing the tube kit over to this anesthesiologist. Great. He's probably done millions of tubes, right? But I don't think he's ever done one.
In a ditch.
In a ditch, right?
Yeah.
With dirt in the airway.
And this is, I'm assuming this was probably when we had you're talking about suctioning, just the old school suction.
Cranking it with one hand, right?
And just like the one you'd get the dentist office, like it just sucks the little slob out. It's not getting any dirt.
Yeah. I had a Yankoa tip on it. But
Yeah.
You know.
know.
Pretty rudimentary.
Yeah.
Yeah.
Crazy.
That totally took us off what we were talking about.
That's a memorable call.
The handoff. That was my handoff. I didn't really know
good
much.
luck.
I just walked up. I kneeled down.
She's messed up.
She's not saying much.
Yeah. What do you got? What's going on? If we've already got a patient wait, wonderful. If not, we can kind of guesstimate that when we get there. What have you done? What meds have you given? Has there been any kind of change in mental status? What way are we trending with that? Anything you can give us as far as what's going on, what you've already done, it's very similar to giving your report at the hospital. It doesn't have to be an hour long. Just hit the main points. It's nothing that's too intimidating.
Because you're gonna fully assess the patient.
Absolutely.
Yeah.
And that's the other thing, too, is to understand that crew, they're still going to fully assess the patient. It's not that they're not taking your word for something. It's just that they're still going to do their assessment. They have to. We've got to take a look as well. I believe everything you just told me, but I still got to take a look at everything myself. So I'm probably going to still roll this patient, look at their back, or assess the airway.
And the ER does the same thing.
Yeah, they're going to do the same thing.
Yeah.
And they should.
Yeah, because it catches things you may miss.
Right.
Yeah, absolutely. How do you approach a patient with a difficult airway, or how do you approach airway management as opposed to what a ground crew would do?
That would really depend on where your protocols line up as a ground crew. Typically, a lot of places don't have a super progressive protocol in place unless they do have RSI. It's more so patients unresponsive, you could tube them. You're not going to be able to medicate them to do it. So when I get in the back, if I'm really concerned about the airway, I'm probably going to take that airway. We're probably going to sedate and paralyze that patient and take that airway if we're truly concerned. But that's the last thing I want to do. I don't want to put you on a ventilator if I don't have to. I don't want to sedate you that heavily if I don't have to. So,
yeah, it's a little easier for us, right? If we drop a tube, we're not carrying ventilators, so we're going to be bagging the patient. We don't have to go through the whole process of setting that up, getting your settings right.
And then how dangerous is it for me to RSI this patient? How much do I need? Have we resuscitated this patient well enough before we do this procedure on them? Because if we've got a super shocky trauma patient with no blood pressure, and then all of a sudden we go dump all this sedation into them and try to tube them, it's very likely we're going to code that patient if they're already in that peri-arrest state. So how well have we resuscitated this patient? Do we need to resuscitate this patient a little bit before we consider this procedure.
And hypotension's a real concern with RSI. Is
Not only like with our sedatives and all, they can drop the blood pressure, but when you go to positive pressure ventilation, you're increasing that intrathoracic pressure, which can lead into hypotension, right?
Right.
Without getting too off into the weeds there. And then having a backup plan in place when we decide if we're going to take this airway. Do we have a backup plan in place? How many times in the back of a truck have you went to tube somebody and then you just can't get it? What's your backup plan? Did you have something else in place, whether you're using a King or a combi tube or whatever at the time? A lot of times we're using iGels now. We teach our crews to have their backup airway out. It needs to be out and visible. So if they have a failure, they can't intubate, they pull that tube and they automatically insert that iGel.
Right.
So just always having a plan B as well.
To diverting time, right? The patient you just described, how much time are you diverting to, if you're going to RSI that patient, how much time are you diverting away from other procedures to do that? Because it takes both of you, right?
Yeah, it takes both of us. It really just depends on what needs to be done, what's already done. A lot of times when you get in the back, they've already got IVs for you. So it's just more so drawing up meds. Do we need to resuscitate? Do we need to get some blood going first? Do we need to run some fluids first? Do we need to do any kind of pressors or something first? But I think that's a big misconception is it's RSI, rapid sequence intubation, right? So I think a lot of people hear the word rapid and they're like, oh, it's a quick procedure.
Right.
It's not. The rapid is the drug induction. It's not a procedure you want to rush through if you don't have to. It's a dangerous thing to do, right? You're taking someone's ability to breathe away from them, essentially. Mm-hmm. Let's call it 10 minutes, 5-10 minutes. Usually you'll push your sedative and give it about a minute or so, and then you'll push your paralytic. You're talking about a minute or two right there on the front end. Get the whole process.
In the setup time too, right?
Yeah, in the setup time too. So, I mean, an easy 10 minutes. But if they need it, they need it.
Right, that's true.
I'll probably have some crews that'll hear that and be like, no, we can do it in less than that. But
So let's talk about managing an airbase, right? Because you now have a stable of highly experienced clinicians. What is that like?
I'm very fortunate where I'm at. I've got a lot of crew members who've been at the company for a long time, 10 years plus. A lot of them are very experienced, very knowledgeable, know how to do their jobs. I'm very fortunate from that standpoint. The day-to-day operational needs of that airbase is what I'm responsible for. So whether that's staffing, budgetary items, anything operationally that keeps us in service, making sure they're all up to date and attending their training and all that stuff clinically, right?
Yeah.
Their certifications are in there. That goes back to making sure any kind of regulatory compliance stuff we're following, right? That falls back on me. Customer engagement. And when I say customer, I don't mean the patient, right? The patient's the patient. The customer is going to be the EMS agencies, the hospitals, things like that. Building, maintaining, sometimes, unfortunately, fixing relationships with the customers. Employee engagement, making sure they feel like they're taken care of and appreciated, or making sure they've got everything they need to do their job as easily as possible. That's just the day-to-day operations are what I take, what I do every day. Yeah.
How much you want to talk about aircraft availability or how many aircraft do you have at that base?
So we have one at our base. I think we're up to 17 or 18 aircraft for our specific company now, continuing to grow, of course. And then there's several other companies in the state as well. So you've got, Georgia has a very well-established HIMSS service, you could say,
right,
across multiple brands, companies. But we have one at the base. So when they're out, a typical run for them is about a 3-hour turnaround time. Of course, one of the things we have to watch is to keep us in service. We've got to have a nurse, we've got to have a paramedic, we've got to have a pilot.
Right.
Managing, making sure we're staffed, working with our maintenance department on when they're going to do maintenance, because there's a lot of routine maintenance that'll take these helicopters out of service for a while. When we do have these out-of-service events, depending on how long they are, we might look at combining with another base who's out of service for something. Maybe they need a nurse that day, and I'm out of service for maintenance, and I'll send my nurse over to them so that we can at least keep that base in service, mitigating things like that.
Right. Mm-hmm. What type of aircraft are you guys flying?
So we fly multiple airframes in the state of Georgia across our company. In the state of Georgia, for our company, we're in Bell 206s, 407s, and then the EC-135s in the state of Georgia, which I think that's everything for us right now. Yeah. So 206, 407, 135. Some other companies fly different things, but that's what we use.
Which do you prefer?
So a lot of people make fun of a 206 because it's a slower airframe. It doesn't make a massive, drastic difference in the runs we're doing. It's not as powerful as like a 407, but it is one of the safest airframes out there. It's very efficient from a financial standpoint. We are moving away from them and moving into more 407s and 429s. Everybody loves the 135. It's just a cool-looking helicopter. It's got the doors in the back that open up, and they can put an EMS stretcher in there, right? So it's a pretty slick-looking aircraft, but I don't know. I've got a love for a 206, and a lot of people will rag on a 206, but I've still got a lot of love for it.
Hey, it's Jason Falvey. Thank you for spending part of your day with me. If something in this episode hit home, maybe it reminded you of a call, a difficult shift, or a lesson learned the hard way, visit us at inserviceemspodcast.com. You'll find more episodes, articles, and resources created for EMS professionals. While you're there, subscribe to the newsletter. And don't forget to follow the show on your favorite podcast platform. Now, let's get in service. What type of weight capacity do you have in that?
So that varies. I'll tell you our crews. Our crews have to be in their flight suits and boots. They cannot be over 230 pounds. So depending on the crew, depends on their weight for the day and how much fuel they have on board and things like that. So if they go in and their weight for the day is a 200-pound patient, that doesn't mean they can not fly anyone over 200 pounds. That just means sitting on the pad with a belly full of fuel, and those two crew members, that's what their max patient weight is, right? And I'm just spitting a number out.
Right.
They can always dump fuel. They can always burn fuel. So less fuel means more weight they can pick up immediately, right? Or we burn fuel if we take off and go to a scene. Where I'm at, a lot of the patients get brought to the base. They just bring them straight to the base. But if we're lifting and have to fly to a scene somewhere, that's going to burn fuel as well. So that number just goes up. They're going to not fit in that aircraft before they hit that weight limit that we just can't fly them. They're just going to hit that max girth. That kind of varies too. It just depends on where they carry their weight at. Men carry their weight different than women. In our aircraft, there's a crossbar. That's when the cot slides in there. They got to go under the crossbar. It's about midway down, depending on where they carry their weight. Will depend on if we can fly them or not. It varies from crew to crew. The crew members cannot be more than 230, though.
Yeah, fully outfitted,
Yep.
right? Yeah.
Flight suit and boots, not helmet.
So you're already factored in all the equipment and stuff you're carrying on board.
Yep. They've got a weight and balance. Anytime we add or remove equipment, the pilot has to update the weight and balance. We can't throw a new piece of equipment on there without consulting with the aviation side because they factor all that stuff in.
Let's talk about risk and safety, because I think that's a huge area, right, with
The biggest.
helicopter EMS.
Yeah.
Let's talk about the risks.
Obviously, our number one thing we look at is weather on every flight. Every flight we take, every request we take, we look at weather. We look at the weather from point A to point B to point C. Our main concern is getting the patient to where they need to go. We don't typically look at, okay, are we going to be able to get back from the hospital? We just want to know that we can get there. And if we get stuck there, we get stuck there.
Right.
But we want to make sure we can safely get the patient picked up and taken to the destination. So we look at weather forecast. We practice a 3 to go, 1 to say no kind of thing. We call that 51%. So if we get a flight request and I'm not feeling it, all I got to say is, hey, I don't feel comfortable with this. It might just be a bad gut feeling. And I can say, I don't feel comfortable with this. Bam, we don't take it. So you have 51% of the vote, right, each person.
Yeah, because there's very little margin for error.
Very little.
Yeah.
Very little. Unfortunately, you still see these HIMS accidents. We've had a few over the past few years across different brands. But in the early 2000s and the 90s, they were a lot more frequent. A lot has been done for safety. All of our aircraft, they all have autopilot. We fly with NVGs at night.
Night vision goggles.
Yep, night vision goggles, sorry.
Yeah.
A lot that's been done to help increase the safety. You'll never make it 100% safe, but a lot's been done in that department.
I was telling you the other day that I was reading some of the safety bulletins, and I don't know how the software we were using at the time to manage safety and risk. For some reason, I had access to flight.
Yeah.
And one Sunday, I'm just reading through the postings and bulletins, and it was astonishing the number of people that walk up to an aircraft on the highway or wherever you're loading or drive right up to it. Like it's no big deal. Yeah.
Yeah. I've seen ambulances almost drive straight under the rotor blades, like coming in hot, right, with a patient, and law enforcement or fire department or whoever just didn't have it, or probably just let the ambulance through thinking they would come on up where they were supposed to, and they drove straight up to the helicopter and almost went under the rotor blades. We were able to get them to stop, but that would have been catastrophic. Spooled up rotor blades, powered on, spinning. But yeah, people, it's like a bug zapper. They're drawn to these helicopters. And so you got to really be aware of that. We always have to have someone keeping an eye out for that. We might task someone at an LZ at a landing zone with that if we're going to be in the back of the ambulance, because typically the pilot's going to be sitting in the aircraft, and he's going to be eyes out as well. But we might task a firefighter or a police officer or a volunteer, fire service member. We might task them as kind of guarding the helicopter, because when they're spooled up, especially these tail rotors, those tail rotors are almost invisible. And if you brush a tail rotor, it's going to be a bad day. A lot of people try to walk up to these aircraft, though. And some hospitals will have fences around their pads. Not all of them do. You get a lot of foot traffic around hospitals. You land out in streets and fields and things like that. Wrecks draw people in. They want to come see what's going on. You're always got to be cognitive of people coming around that aircraft. Same thing when you're taking the patient with the ambulance crew to load them into the aircraft. We keep one crew member, typically walks in the back to keep an eye, kind of herding everyone, right? Like keeping everyone kind of herded in close to where they don't step too far one way or the other as we approach the aircraft. Looking for debris, or a lot of times an EMT or somebody might walk to the aircraft to help load the patient, have a hat on. We got to make sure the hats are off because we don't want them to get pulled off in the rotor wash and get caught up in the tail rotor or something like that, the big issue that grounds the aircraft.
Yeah, and I did see a video a while back of helicopter was coming into an air base, was landing near the fuel ball, or it was going to refuel, and a fire extinguisher cover got sucked up into the tail rotor.
Anything can become dangerous debris. We do a lot of LZ classes in our communities, and that's one of the things we focus on. When you're going to be setting a landing zone up, do a sweep looking for debris, because we're going to stir up a lot of debris when we come in due to the rotor wash.
Right.
And it'll blow up and come back down, or it can blow into the tail rotor. It could blow over and hit someone. It could do anything. Now what you're talking about, that sounds like it was at their base, so it was something they had missed, right? They needed to make sure it's secure. That's one thing we try to do, is do our walk-arounds and make sure everything's secure that could blow off. We moved to these hard covers over our extinguishers, and so that video might be one of the things that influenced. We did that a few years ago, these hard covers that go over the extinguishers.
Yeah.
So,
any close calls?
Well, like the one with the guy almost drove the ambulance under the rotor blades, that probably would have been a bad day for me, and definitely for him and the pilot, because I was standing about 20 yards away probably. I had one night, we were flying over the middle of nowhere in Alabama, and I had my night vision flipped up. I was doing some patient care, talking to the patient. I don't remember exactly what was wrong, but doing some type of patient care. And I remember seeing a little blip of a light out of my peripheral vision, out of the corner of my eye. Didn't think much of it, just thought it was a tower in the distance. And then it blinked again. And I said, man, that seems like it was a little closer than it was a second ago. And so just that instinct, I looked. And as I looked, look, I'm not a military plane expert or anything, so I'll just say a C-130. It could have been something totally different. It was a big plane. Went directly under us. About the same time I saw it, the pilot saw it. And it's pitch black dark out. Like I said, middle of nowhere, no moon illumination really that night that I remember. And so about the same time I saw it, the pilot saw it. We exchanged some, very nice words.
It was nice knowing you.
Yeah. Some very colorful words came out.
Yeah, I'm sure it wasn't that.
I asked him, man, did you see that? He's like, oh, yeah. They never even showed up on his radar. I would imagine they saw us. We were on their radar. It was a military plane.
Right.
We never saw them. I don't know if they can control who can see them, who can't. We never saw them. They went directly under us. We were probably flying at 100 feet. So they went under us So it was very close. I almost felt like I could feel it when it went under, and it was, I don't know if I did or I didn't, but that was a close call. Maybe those guys in that plane would have said, no, we knew y'all were there. I've been very fortunate because a lot of the close calls are pretty bad, right? They end up being something pretty bad if something ends up happening. So very fortunate.
And I was talking to another flight medic who said that crop dusters seem to be the bane of his existence. They come out of nowhere, especially on scene flights.
Yeah, I've seen some small planes coming overhead when you're fixing to leave, aren't communicating. I've seen some sketchy jets, like small little private jets flying right off the treetops, like super fast. I don't know what they were doing. I don't know where they were going or what they had in it, but yeah, kind of that's
what could that be?
Yeah, right off the treetops, like they didn't want people to see them. I've seen that. One thing though that's probably becoming the bane of our existence are a lot of these drones.
Yeah.
It seems like a few years ago you were seeing a lot of the personal drones you'd had to be eyes out for, right? But now you're starting to see so many commercially utilized drones. Amazon's got these drone facilities in the metro Atlanta area and other places too. Walmart is delivering with drones now. So they're all following a lot of the FAA regulations and everything, and they won't come near us or not supposed to come near us, and we're supposed to be able to see them on our radars and everything. But it's still just more air traffic in an already congested area, especially in this metro Atlanta area, or you're getting close to Hartsfield. That's a super congested area, right?
Yeah.
So the drones are probably a big concern of mine right now, especially because every kid's got a drone now, it seems like.
Yeah. I got a drone.
Yeah. And they're awesome. They're awesome.
It's cool.
It's pretty cool. I know there's a lot of regulations that come along with that, what you can do, what you can't do. You got licenses to do certain things, right?
Well, it also has in the software a certain altitude function on it. It prevents it from going up too high. And it's not very high. It's like 100 feet or 150 feet or something.
What do people love to do? They see a bad accident or something nearby. I'm going to throw my drone up and get a better view of it.
Yeah.
They might only be 100 feet off the ground, but they're hovering around, and then here comes a helicopter. We've had helicopters abort landings because here comes a little drone scooting across.
Let me get in there and get a picture of that pilot.
Yeah, get a picture.
God.
Yeah.
And you wouldn't think it would be able to cause that much damage, but...
Man, you can have a bird. A bird will take a helicopter down. That'll scare you, hitting a little Tweety bird and hear it thud against the windscreen. If we know we have a known bird strike, even if it's a small Tweety bird, once we get to where we're going, we'll do an inspection and make sure everything looks good because you don't want it to have sucked into your engine or something like that.
Yeah, engines don't like that.
Yeah, they're not a fan of birds.
So what do you think the conversation about helicopter EMS is going to be? What do you think it's going to be in 5 or 10 years? What do you think you're going to be talking about?
I think we're going to see more and more drones.
Your reaction to that was pretty stark.
I don't know what 5 years. I don't know if we're going to see a ton of difference.
But I would imagine 10 years down the road, drones we might have flying vehicles by then.
In 10 years, I wouldn't be surprised if you already see people doing it. In 5 years, honestly, I don't think we're going to see it locally. But I think you're going to already see some places, probably extremely rural areas, doing some type of unmanned or unpiloted, because I'm sure they'll have to have a medical crew, right? Drone response.
Have you seen that one they're using in California? It flies a single medic.
Yeah.
It just looks like a drone.
Yeah, it looks like a big drone. He's piloting it. I've seen that. And that's what's leading me to think there's no telling where we're going to be in 5 or 10 years.
Yeah.
I saw that the other day, though. I was reading about it. Super cool
Yeah,
concept.
just landed in a cul-de-sac. The guy pops the windscreen.
It's like a first responder. Yeah, he pops out. And I don't know. I hope increasing safety tools or standards or something, things like that. I hope we see that. But, man, the way technology is moving right now and the way AI is moving right now, honestly, I don't know where we're going to be.
What about ECMO?
What about it?
Are you going to see more of that on the helicopter?
I think you'll see more people becoming ECMO capable and at least flying it, and it might be them working with a team out of hospitals and flying these teams and these aircrafts, because you do have to have a bigger aircraft for it. I think you're going to start seeing a lot more of it.
We're already starting to see it in the ground protocols now of going to an ECMO-capable facility, but
yeah.
Are you flying much ECMO?
We're not, because you've got to have a larger airframe. That might be something they're doing with the 145 in the near future. I don't deal with that base.
Right.
But we are starting to see it, and I've seen these hospital teams that have the bigger 45s and things like that. I've seen them doing it. But yeah, you are starting to see a lot of these ground protocols, especially with refractory VFib or whatever, and they're saying transport them instead of working them on scene for so long, throw them and take them to an ECMO-capable facility. And they're doing ECMO on these patients successfully.
Yeah.
I think you are going to start seeing more of it. I saw one of the local hospitals the other day send a ground truck an hour and a half down the road with their whole ECMO team and cannulated a patient right there in this little rural ER the other day.
Wow.
Yeah, it's pretty cool stuff.
It really is.
Have you ever seen them cannulate someone on ECMO?
I have not seen them cannulated, but I have seen patients on ECMO. And
your jaw will drop.
yeah.
Yeah.
Wow.
Yeah, that's what
An
they do.
ECMO expert.
Yeah, but I believe
I'm going to get somebody, an ECMO physician.
it's
on.
super interesting. I took a guy, it was interesting. It was right before, like, end of 2019, before the world changed, right? Picked a guy up, and he was super sick. And they were like, we thought it was going to be flu, and he was a young guy. We thought it was going to be flu, but he was flu negative. They couldn't figure out what was wrong with him. Now, of course, looking back, right before everything changed in 2020, they took him into the hospital. We were dropping him off and he was going for ECMO. Within 5 minutes of moving him in there, they were shoving hoses inside of him. It looked like garden hoses going straight into his leg. And I was like, oh, my goodness. And it was just so quick.
Yeah.
So they were really good at what they do.
Wow. One of our crews brought in a patient with a saddle PE maybe a couple months ago. And I just happened to be there. I had gone into the ER that day and was talking to the crew, and our medical director was there, and he's like, hey, I just sent them upstairs. That patient you brought in had a saddle PA. They've got an interventional cardiologist.
Nice.
Let's go upstairs and look at it.
Oh,
yeah. Well, I have to look at what the system's doing, right? I'm like, yeah, we're doing well. Let's go. That was the coolest thing to watch.
Did you watch them?
Oh, yeah.
Wow.
Yeah, awesome.
I've not got to watch it. I've seen them. Like
Wicked awesome.
Yeah. I've seen pictures of large vessel occlusion patients, and where they've taken it out, and I've seen them show me the clot,
Yeah.
But I've not seen that, so I bet it was
unbelievable.
It's crazy what they can do.
So my frame of reference, when I came out of EMT school, I had to do some ER observation time, and they local rescue brought in a patient having a stroke. It affected the patient's speech center. I remember the physician evaluating him and then walks away and says to me, yeah, that's it for this guy. Mm-hmm. They didn't have TPA. It wasn't widely available at the time.
Wow.
No clot retrieval. And he's like, yeah, this is it for him. And he was like 57, 58 years old. Wow, we are so far from that, right? Because that PE patient, what would have happened to that guy? You wouldn't even have known, probably, 20 years ago.
Yeah.
He would have expired.
Yeah.
Right? Yeah.
It's interesting thinking about because you were talking about where is HIMSS going to go, but healthcare in general and pre-hospital care or emergency care, where is it going to go in another 10 years? Just the changes I've seen in my short time in healthcare. I think it'll be really cool.
Yeah, right. Let's talk about crew resource management.
Yeah. So before diving really into crew resource management, I would say what you were asking about how we could adopt it over into other EMS services, mm-hmm. That's one of the things that I really wanted to bring with me when I came over to the ground operation management from air, and I was still involved with air, is there's so much focus on safety on the air, right? Like we focus so much on safety.
High risk environment.
Yeah. But there's also
but so is ground, right?
Exactly. But there were so many things that we were doing on the ground that I was like, man, we could be better at this, right? And we've always done it this way, kind of stuff, right?
Yeah, but we do have some really cool safety vests that we wear.
We do got really cool safety vests, but just just the shift work that we're doing, or just how fit for duty people are, how much rest did they have before they come in. Those are things that, I just don't think we think about as much. And I hate to say it like that. And maybe you disagree with me, but I just feel like, we haven't focused on that stuff as well as we should have in the past on the ground side. as we do on air. Every morning these guys and girls come in for their shift at the base. They sit down, the two of them and their pilot, and they make sure all three of them are fit for duty. They do a daily brief. What's the weather look like? How's everybody feeling? All that. They're required to have their 10 hours of rest beforehand. And if something's off there, I get notified. And I don't feel like we've always done the best job with that on the ground side.
Yeah, I have to agree with you. And I've sent people home or pulled people out of service because they probably shouldn't be out on the road. Either they're exhausted, sick, running a fever.
Pulling something up I was looking at.
Or, they've just run the most horrific call, and this person is not in the headspace they need to be in to be back out on the road.
Yeah. And, how many times in your career did you work a 48 or a 72? Or something?
Yeah.
You know what I mean?
Yep.
And there are a lot of people who would get really mad hearing me say this, but I'm really no longer a believer on the ambulance, at least in a 24-hour shift. It does have its place, but anything past that, I can support a 24-hour shift, but anything past that, I no longer support. And I used to work 48s, you know what I mean? Like that was what I did, and I had to get by with just with our salaries and all, right? Like I had to work 48s.
Right.
But it's just so dangerous. It's so dangerous. We cannot do that on the air. We work, it's a 24-hour shift. They can extend 4 hours if they have to, but after that they're done. And they have to have 10 hours rest before they come in. And that's something when I went over to the ground unit I was with, it was right there next door to my air base. And that was something I implemented. It was like, hey, we are no longer doing more than 24-hour shifts. And that ruffled some feathers because I had a lot of people doing 36s. They were doing 312s in a row. Or they were doing, I don't know if anybody was doing a 48. I can't remember what the specific policy was for the company at the time, but whatever it was people were still working 36s, and it was so dangerous.
It's a long shift, and I can see in very rural communities where maybe you're running 3 calls in a 12-hour period of time, maybe 4 or 5 calls in a 24-hour period of time. Yeah, and you have plenty of downtime, and you have a station that you can rest in. But if you're in a truck on the street for 24 hours, 36 hours, that's a long time.
It's a long time. It's a very long time. But just kind of, and I'm steering more towards the ground talk with that. But just as far as leadership, looking at safety and all from a leadership standpoint with air, I think it's just so important to be a supportive leader. I very much want my crews to be able to feel safe to contact me with any kind of concerns they have if they aren't well rested and know that I'm going to support that. We have what we call crew rest, which means they can call me at any given time and say, hey, we need to take crew rest, which is an automatic 4 hours. It can be less if they're saying, hey, I just give me an hour, I'll do that. But it's typically an automatic 4 hours we give them, and they are expected to rest. So they've been out flying all day and all night, and they call me at 3 a.m. Hey, I can't do another one safely. Then they are expected to go rest. They don't need to be working on a chart. They don't need to be restocking. They don't need to be cleaning. They need to go get in their bed, lay down, and rest. And we take them out of service for that. And it's all a safety. It's all from a safety standpoint. It takes all 3 of those crew members on every single flight. Everybody's eyes out. Everybody's communicating. And so if one person's off from that could be catastrophic. Just being supportive of them and being available to them to have those kind of conversations. I try to lay eyes on them. I don't hit every crew every single week, but try to lay eyes on them, make sure everything's going good, make sure their home life's going good, because if your home life's not going good, work life's not going to go good either. Yeah.
Yeah, absolutely. Yeah. Man, I got to move over to air.
Yeah. We're talking about career resource management, not only just like following our procedures, we do a walk around before every flight. Okay. So the crew goes out there and they do a full walk around of the aircraft. They're looking for making sure all the latches are done, all the doors are shut, things are locked that are supposed to be locked. There's no oil or grease or something somewhere where there's not supposed to be. Looking for debris around the aircraft. They do that before every single flight. So it's really just following through, making sure our crews are following through with those kind of procedures, making sure they're communicating with each other. If they see something, say something. Maybe I've got a nurse who's looking out the right window and sees a plane a mile off to the right, and making sure she says that. And whether the pilot's already seen it or not, verbalizing that. Hey, I got a plane at 3 o'clock. I've got a plane at 3 o'clock or at 2 o'clock off the nose. And just communicating those things. Because a lot of accidents they were very avoidable. They were due to error, or maybe somebody didn't speak up and say something. And so just making sure everyone feels like there's a safe environment there to speak up as well with any kind of safety concerns. We do monthly base safety meetings. Every base does that within our company every single month. At my base, we start every meeting off with a safety concern. We carry safety challenge coins with us that we show as a reminder for our safety. And then we go into a safety topic, and there are different things. They might be hot refueling one month, which means refueling when the aircraft's running or something. Or another month, it might be emergency egress. Different topics each month throughout the year. But we do that every month. And then we always lead into other discussion as well. Sometimes it turns into a vent session about things. Sometimes we'll do some education. We'll do things like that. But the point of the meeting is it's about safety.
That's cool. Helicopter, I saw one over here at the hospital. It might have been yesterday or the day before. I don't know, the days run together at some point. The only reason why I brought it up is they were doing a walk around of that aircraft as he was spooling up, touching every compartment, making sure the doors are latched,
You'll see them, they'll run their arm over everything because there's lots of little latches. Make sure the fuel tank is closed, making sure that aft door is closed.
It looked like the medic and the nurse pretty much went over the same thing. Mm-hmm. Yeah.
They each do it. They start on the opposite side. So typically the medic's on the left side of the aircraft. He'll start
behind the pilot,
let the nurse do their walk around, hop in, make sure their door's nice and shut, then do their walk around the opposite way, and they'll hop in.
Yeah.
And they double check each other.
Yeah. That was nice to see.
Yeah. Let me know if you don't see it. If you don't see it, I got to follow up on it.
Well, they were in the break room for a while, and I saw this woman. I was out in the bay talking to a crew, and a woman just happened to walk up. The doors are open, the aircraft's sitting there, and she walks up, and she's just curious, looking around, looking in there. I'm thinking to myself, is she going to get in that thing?
Oh, people will try. People will try.
I bet. And she turns around and sees me watching her, and she's like, my daughter's a diabetic. I'm thinking, what the hell does that have to do with anything?
No, that's funny, man. You're talking about memorable stuff, too, or people climbing into the aircraft. I remember, we were on a shooting scene one night. This is on the ground. And there were a couple people shot that we knew of. And one of the EMTs went to go get the stretcher out of the ambulance. He didn't have it with him. He opened the doors to the back of his unit, and there was a guy already sitting on his stretcher that was like, I've been shot. He was just waiting on him. He was in the back just waiting on him.
Wow.
I got to go.
He climbed in the back.
He was just waiting, too. The doors are shut. When you shut the doors, it's dark in the back.
Yeah.
The light, he didn't have the dome lights on, so he was just back there in the dark.
Yeah. My neighbor's kid had a seizure. Mm-hmm. My neighbor calls my wife, and she says, I'll send Jason down there. So I walked down to my neighbor's house, and it was like a 2-year-old. And, he had a seizure right there when they handed him to me. So I'm like, call 911. Mm-hmm. And they went into this. I know panic might be too rough of a word to use.
We're excited.
Okay. Yeah, that's it. And they hand me the phone, right? I'm holding the kid, right? So call 911. Tell them what they got. And the ambulance is coming. And I happen to know all those guys that were working the ambulance. And so I'm like, all right, strip the kid down. He had to run into temperature. It was febrile. And I'm like, grab a blanket. We'll meet him right as they pull up front. We'll just climb right in the back. Mm-hmm. Save them some time. Ambulance pulls up. I walk out. They open the back doors. Boom. Baby goes in the back. They close the back doors. So I'm standing outside the ambulance with this police officer, and we're talking. And I kept looking at the back doors because it was dark. in the back. And I'm thinking, what do they have, limousine tint on their
Yeah.
windows? Like, it was dark. And maybe 5 minutes goes by, 6 minutes goes by. I open the back door. All the lights are off. They've got flashlights. It was an electrical failure. They're sitting
my
in the dark.
gosh.
I'm like, yeah, these things happen.
They do. If you ride ambulance long enough, it's.
And I'm thinking, why are you sitting in the back? It's dark.
They probably knew they had that problem, but the other truck probably didn't have working AC. So they're like, you know what? I'd rather have no
Yeah,
power in the back.
This is in the middle of winter in the Northeast. Yeah.
Oof.
Yeah. All right, let's swerve back into, let's talk about debriefing. It's kind of big
Yeah.
in air.
So we debrief after every flight. I mentioned we do a debrief after every flight that we do. A lot of times there's nothing to it. Business as usual. We went from here to here. Everybody signs it. The nurse, the medic, and the pilot sign it. But anything they run into, any kind of issues they had, they'll note that in the debrief. And if they call me and tell me that there was a problem, that's one of the first things I'm going to go reference is the debrief. A lot of times they go tell me about a problem, and then I go and look. And I'm like, you didn't even record it in the debrief. You got to put that in there. They do a debrief after every single flight. So if they ran into any issues, they were delayed for whatever reason, anything of importance, they'll throw in that debrief. But we do that after every flight, and if they need to be reviewed, we'll review them because sometimes there's lessons to be learned there. There's lessons that need to be shared with the other crews, which is a big thing.
What is the advantage of that? Well, the advantage, there are some obvious advantages to doing that, but do you feel that that really builds a bond between, does that build trust more?
Yeah, I think it does. I think the more you communicate amongst each other, you're living together already, right? Every shift you're there, you're living with your crew. But just the more communication you have, you're going to build trust, you're going to build comfort, you're going to feel more comfortable bringing up these issues. Somebody might be nervous because maybe it was an issue with how the pilot did something. Or maybe it was an issue with, maybe I'm with you and I had an issue with Jason, the way he did whatever. And I'm friends with Jason. I don't want to tell him he did that. But the more you communicate and you get that comfort down where you can have these discussions and things that need to be brought up, you feel safe to do that. Because like I said, there's something to be learned. If there was an issue that we need to discuss in the debrief, there's probably something that needs to be learned there, right?
Right.
Does that make sense?
Yeah. What do you think some of the common issues are that come up? Is it patient management? Things that come up in the debriefs?
No, not typically. I don't deal with a ton of them.
Interpersonal conflict?
It can be something, and it might not even be anything that has to do with the three of them. It might be we had the LZ that Country Town Volunteer Fire Department set up for us. We had to abort that LZ and ask them to set up another one. It might be something that simple.
Right.
What is that telling me? We might need to go do some LZ training in that community, whatever that town is. We'll do this landing zone class or something. It's also letting other crews know, hey, be aware. They've recently set up a bad LZ for us. So be aware of that when you're coming in there. Be aware. We might have to move the zone, whatever. So it's not always just stuff within us. It's just anything that we experience, right? Trees. There's some trees that are getting pretty big on the edge of this helipad at ABC Hospital. Keep an eye out for that. We'll put that kind of stuff in there. And then when I see they've written that down, I can take that to that hospital and say, hey, could y'all maybe look at trimming these trees up?
Right.
Navigating problems before they become problems.
Right.
It's things like that, too. It's not always just Jason messed up or Ricky could have done this different. It's anything they've experienced that they need to bring up, they feel like needs to be brought up.
Is there one patient or any particular mission that fundamentally changed how you lead or practice flight medicine?
I don't know if I've had anything that has changed my practice.
Right.
Probably.
How about your leadership style? Because you're dealing with a group of people that are highly trained, highly skilled providers. I don't want to say type A, but certainly.
A lot of type A's.
Yeah. Hard chargers. Yeah.
I think.
Patient advocates.
Yep. I think I've always been a patient advocate, right? And so I still have that mindset. I still want to be able to do everything I can to help get a patient to where they need to go, even though I'm not physically the one doing it anymore. I know as a flight crew member, you're already task saturated. Even if you're just at bedside at the hospital or something, you're already task saturated. So anything that you need help navigating, I don't mind helping with. Plenty of times my crews have called me and, hey, they're having some kind of issue. Can I make some phone calls, or can I set up ground transport for them because maybe weather's moved in? Different things like that. But just really trying to be supportive of those guys and girls because I've been there. I know how not all of our leadership with this company has been in the back of the aircraft. Some of them just come in as leaders. They didn't come up as a crew member. Not that that's a bad thing. There's nothing wrong with that. But it does give me a perspective of having done it with them before, having done the transports before. And I can look at it from the perspective of a crew member, understanding of some of the decisions that my crews make. Sometimes it's easy for me to say, what in the world were y'all thinking? Why did y'all do this, or why did y'all do that? But then when I remember they're task saturated, they're having to make quick decisions. Yeah, it can be. It's a very fine line to balance between this is something I've got to be concerned with from a business standpoint.
Right.
But I also still care about you, your safety, and the decisions you're making. It's a fine line you got to tread sometimes.
Yeah.
We have a job to do that is a business.
Mm-hmm. Healthcare in general, right? It's just a business.
Yeah. Sometimes that's a really not fun side to be on, but we're still also in the business of taking care of people. I always want my people to know that. While I am in leadership, I give you directives you might not like. I ask you to do things that you might feel are pointless sometimes. I still very much care about patients. I'm still an advocate for patients and patient-focused. And whether you see it or not, this business is still very patient-focused.
Right.
Just trying to balance between the two can be difficult sometimes.
Right.
Yeah.
We're going to move into the lightning round.
Yeah.
All right.
Okay.
What do you think the most underrated piece of equipment you carry is? You can do ground or air.
Yeah.
Paramedic has access to.
I almost hate myself for saying this because I know we talked a little bit about it. There's some great pieces of equipment on trucks and helicopters and all that, but I truly think it's your phone. And I told you yesterday that it used to be the field guides. We used to carry the field guides, and I still keep one. It's like a lucky rabbit's foot. I keep it if I'm riding a truck, or when I was flying, I kept it on me. It's like the 2010 AHA field guide, man. It's old, right?
Yeah.
And so it's out of date, but I like to have it on me. But now I'm going to say phone just because I feel like that's probably what you'd utilize for a field guide now.
Yeah.
I think it's really great for people to know a lot of their protocols, but there is absolutely no shame in pulling out your protocols and looking over something, especially if it's something you don't do a lot of. Maybe it's a pediatric and you want to double check something. Maybe you do it on the way to the call while your partner's driving. You pull out your phone. Maybe I'm going to a seasoned kid. Let me double check my pediatric seizure dosages, right?
Right.
Things that there's no shame in that.
No.
I think that's being a good provider, a responsible provider. I think a lot of people let ego get in the way and think they have to know everything. But, yeah, man, it's such a great tool to have, whether it's pulling out protocols, looking at a field guide, maybe don't recognize a medication that a patient takes, your calculator, because they got apps now that help you with figuring out a drip rate or something, which I do think core level, you should be able to do those kind of things, right?
Mm-hmm.
But, man, when it's high acuity, low frequency, and it's chaotic, a lot of times it's hard to remember how to do some of those things.
Yeah, it decreases the cognitive overload of the moment.
The cognitive overload. If I can pull something out to help me navigate that instead of going into panic mode, I'm all about it.
Right.
I hate myself for saying that because I hate us having our cell phones out all the time nowadays, but I do think it's such an incredible tool.
What do you think one habit every paramedic should develop? Whether it's a ground crew or a flight crew, what's the one habit do you think people should develop that'll make them better or safer or more efficient?
Slowing down.
Yeah.
Slowing down and moving in a calm way, right? That can change the entire mood of a chaotic scene, of a chaotic hospital room. Whatever your setting is that you're in, this chaotic setting, whether it's a sick patient in emergency room number 1, they're trying to push out on a transfer, or you're on a chaotic scene with multiple providers and bystanders and law enforcement. If you are that calming presence, it really can change the entire feel of that situation.
Yeah.
Somebody told me that one time. That was probably one of the biggest compliments I ever got. One of the paramedics I trained under, he had that. And I remember I was like, man, it didn't matter what was going on. He was cool as a cucumber all the time. And I was like, God, that's what I want to be like, you know?
Yeah.
Because it made me feel better. It made me feel like we had things under control. And so I kind of modeled myself after that until one day we were debriefing after a bad call on the ground one time. And he said, I just always look over at Ricky, and if he's not panicking, I know we're good. What he didn't know is in my head I was probably panicking, but I didn't show it. So I think having a calm presence, slowing down a little bit, not getting in a rush, that's a huge skill. And it's a really hard skill to develop sometimes. Some people it comes really easy, but it can be a really difficult skill to develop. But I think it's very important to be able to control the room or the scene, whatever your situation is.
Yeah. I think it's a skill that you can develop.
Mm-hmm.
Yeah. But you have to be intentional about it.
Yes.
Yeah.
Yep. Delegating tasks. You don't have to do everything. Just because you've got a P on your arm now doesn't mean you have to do everything.
Right.
You can do less than you used to do. Delegate tasks.
What do you think the most overused intervention is? If you don't like it, I'll give you something else. Because I'm sitting here, I read the question, I'm like, I know.
I mean,
what do you say?
I was going to say, what do you say? IVs, overused.
Stair chair.
Oh, God, underused.
No.
Sometimes I want to say the cardiac monitor. And the reason is because sometimes I'll see people throw every single patient on the cardiac monitor, but then they won't throw a patient they need to throw on the cardiac monitor.
Yeah.
And then they'll leave them on it until we move them over to the room. And then it just gets in the way at that point.
Yeah.
And I'm like, man, we can go on and unhook this thing and leave it in the truck. They don't need to be on it. They stub their
The
toe.
leads are getting caught under the cot wheels.
I see people overutilizing end-tidal CO2 on patients that don't need it on for any reason. It's a wonderful tool. I love it on the nasal capno, but not every person needs it, and it's an expensive tool if they don't need it.
Mm-hmm. I think it's good if you get into the habit of using it more and you're integrating that into your care. I could see where that would be very valuable.
I can live with that. If it's needed and it's valuable to your care and you're using it correctly, absolutely, man. But I see those getting utilized the wrong way, too. I see people trying to high-flow oxygenate with them, and capnos only go up to 4 L. So, I don't know. That's a hard question to answer.
One more. I'm going to throw one more at you. What's one protocol you'd like to see change from a ground perspective?
From a ground perspective,
Gut feeling right now. Go.
I think more blood products.
Yeah?
I think more blood products. It's one of the most incredible interventions I've ever been a part of when we started utilizing it. And you're seeing so many people move to it now. There's a massive downside because if there's overutilization, if we're wasting blood or whatever, just wastefulness of blood because we're already in such a blood crisis, but it's saving so many lives. I think the more patients that have access to blood products, it's an incredible tool to have. It is truly saving people's lives before they get to the hospital.
Yeah. Mm-hmm. Yeah, I agree with that. In the county that you were, the ground operation that you were managing there for a while, they have blood down there now.
No, they do not. We were working on that project, but it got a snag and it got held up. But I'm hoping in the future. We have it at the air service in that county.
Yeah.
But we do not have it. We were working on that project, but it hit a snag.
Is it acquiring blood?
I think it was from the cost standpoint. It was a financial thing, yeah. They're not
Run QRVs, right?
every now and then they'll run one depending on staffing, and it'll be more so on like a Friday, Saturday, Sunday. They don't get a subsidy down there. Subsidy's a game changer, right?
Yeah.
For any service.
You know, there really haven't been any significant increases in Medicare or Medicaid in 30 years.
Oh, no. I don't know what's going to happen with it, but something's got to be done. Something's got to be done about reimbursement.
Listen, thank you so much for coming in and doing this. We've talked about it for a little bit. I appreciate you sitting down and speaking with me and spending your time on a Friday morning.
Yeah, thank you.
What is one of the biggest myths with, let me rephrase this. What are some of the biggest myths, this damn myths, it's going to get me.
That's all right.
What are some of the biggest misconceptions about?
Thank you for listening to In Service, the EMS Podcast, where frontline experience meets leadership insight. If you have found value in this conversation, please like, subscribe, share, and leave a comment. You will find links in the episode notes.